Welcome to Qual-ED. This is your host, Arjun Venkatesh, where we're exploring quality in emergency care. Today's a special podcast episode. We are kicking off our new emergency quality network, Venous Thromboembolism Collaborative. I'm joined today by my co-lead from that work, Dr. John Sather, who's an emergency physician at Yale, who has a ton of experience developing quality measures around diagnosis for PE. And he's also been a quality director in an ED as well. And so we're going to try to cover in a whirlwind today what's going on in the world of quality improvement, pulmonary embolism, and at the end of the day, really get at how this can improve care in the ED, make improvements in diagnoses for patients, but also support our emergency physicians and clinicians around the country. John, welcome to the show.
Arjun, thanks. Happy to be here.
So, John, I want to dig into this because I think quality improvement always gets a pretty bad rap. And part of that is because it's usually things outside of emergency medicine, meaning that, there's a new CMS metric on sepsis or the Joint Commission wants something fixed. And so we're kind of reactive and we say, okay, well, now we have to do a QI project to address that concern. And sometimes it doesn't feel like the biggest or most important problem in our ED. In this space around diagnosis and PE, it's kind of different. There is no CMS metric out there. There is no Joint Commission requirement. And it is something that sort of we're trying to develop within emergency medicine. What's your experience been sort of trying to create a new quality wave of attention around PE and diagnosis?
Good question, Arjun. And I think in my experience, you mentioned that I'm a quality director. This is kind of what I do. When I'm not trying to develop measures, I'm actually running an active QI program that involves a lot of case review. You use the word reactive, and I think that's probably the linchpin to sort of my movement towards the scholarly focus that I've taken. We tend in QI to react to things, which is a case referral of a missed PE or mismanagement of a PE, or as you mentioned, react to sort of external pressures to sort of put something on our radar as a system. And I think that's plagued our efforts to really understand performance and diagnosis and management of disease in general, but as we speak about venous thromboembolism, we don't know what the baseline performance is. We often are reacting to reported cases of misses or standards imposed upon us that suggest we're not doing well at a certain diagnosis with respect to making that diagnosis or treating it. And so I came to this with this idea that there's been a ton of research on venous thromboembolism front-ended or focusing on the front end of appropriate resource utilization. And there's not a lot of data out there about how are we actually doing in terms of performance that translates to patient outcomes. So I came at this with the idea that we need balance measures to really understand performance. And to do so, we really need to find diagnoses and be able to assess that performance to the best of our abilities. And that has proven to be extremely challenging. And so a lot of the work that I've done over the past 5 years is to try to tackle that. How do we develop a balanced measure that gives the best of our abilities a comprehensive assessment of performance in PE diagnosis and management?
So exactly, John. I think that's the hardest thing about this, which is, often in healthcare, we're looking for magic bullets. One measure, if we improve on it, healthcare gets better, patient outcomes are amazing. And that's just not what the real world that we live in. Like you said, we need a bunch of these balancing measures because one moment we want to promote good stewardship of use of our CT scanners, not expose patients to radiation and increase costs. On the other hand, like you said, we also don't want to miss PEs. We want to make the diagnosis and help people get timely treatment. I think this gets hard because the media coverage, or even like probably being a quality director, when you get a complaint from another service or another provider, it's, oh, this one PE was missed. And it feels to me like we, in the same way that we talk about in the patient safety movement, having a just culture with psychological safety for individuals to be able to improve their care, we almost don't have the psychological safety as a specialty to address diagnosis, because we're so afraid of getting attacked for this thing being missed or another thing being missed, and it's so hard to be perfect. How do you address that? Like, how's your conversation been as you've been sort of at all these national meetings around emergency care and diagnosis?
I think I'll try to use an analogy that I've often brought to the table when trying to set up the concept of balance measures. You're absolutely right in that when we try to adjust or enhance physician or system performance, there's a lot of defensiveness. And that's understandable. We want to go to the bedside, or system wants to bring providers to the bedside to help patients improve their outcomes in health. And often we focus on appropriate diagnosis and appropriate management. I think we've ushered in a new era over the last 10 to 20 years, particularly in venous thromboembolism. We want to also usher in wise resource utilization, understanding the risks and costs if we don't do so. However, at the end of the day, any feedback provided designed to improve physician and performance is always regarded in somewhat of a negative light. Contrast that with sort of the professional sports world. And I think this is kind of where I take this. We are professionals in emergency medicine. We've trained, we're paid to do a professional job as we go to the bedside. Yet when you compare the performance support model in traditional QI programs with that of a professional athlete, it's vastly different, right? A hitter in baseball is well aware that every time he goes to bat, he is supported by a group of folks looking at his metrics, observing how he hits regarding certain types of pitchers in certain types of parks. And even if there is some failure, that batter, that hitter, appreciates the feedback he gets from his professional support staff to constantly improve. It's part of the profession. We don't have that. And I think the idea is to have a much more balanced sense of measurement such that it becomes an accepted part of being a clinician. We want that. I'd like to see an era where quality and safety directors are empowered by metrics that actually have meaning, such that clinicians who see that feedback, receive that feedback, welcome it, because they understand that it is, one, valid, it's reliable, but it's designed to help them improve the care they give to the patient.
You think we're there in the sense of people being ready and open to that kind of feedback, that emergency physicians will sort of are hungry for that information?
I don't know if I'd use the word hungry. I still think we need to overcome the barrier in that much of our current QI approach hasn't been comprehensive enough, hasn't been valid, and hasn't been reliable enough to engender that kind of respect from the clinician. And I think that's what we're trying to overcome.
Yeah, and I think, and I always joke that thank God for the EHR, because everybody hates EHR so much that they can't hate quality measures as much. And so it bought us a little bit of a window. But I think you're right in the sense that if people were to have some more positive experiences, right, recognize that they could get data, improve quality, see that turns into something tangibly for patients, and that it's not followed by some sort of firm carrot or stick, that it's sort of a part of practice, like, part of being professionals, they would, I think, view it very, very differently. And, that's actually part of the ethos of Equal. When we built the Equal network and we started doing all these quality improvement projects, I found that one of the first things I had to tell everybody when we were trying to bring EDs into Equal was that we weren't doing measurement to put them up on a public scorecard. We weren't doing measurement to decide any of their payments, but that actually the data was just for them, and that the benchmarking data was just to compare their ED to other EDs, but that it was totally confidential and just for them to use for how they wanted to guide local projects, and that a win was just participation, not that it was your score defining you as a good or bad ED, good or bad emergency physician. And we've lost a lot of that in quality measurement. And I think the more we can sort of bring that back in, the more we can sort of lean into what are really, many physicians are very analytic people, and they really do want to do better. And I think everybody would agree that if you didn't have metrics, and you didn't have any data, and you didn't know how you were doing, we're just flying blind. And so it's really about shifting the world, right? Trying to get to more of that kind of thinking.
And I think there's another side to that, Arjun. I think much like the analogy between the batting average approach, metrics that help guide performance for a baseball player, built into that is that the batter is not going to go and bat 100%.
Yeah.
Right? There's a natural error rate shaped by the realities of the profession. And I also think part of the job in quality and safety is to acknowledge the very real uncertainty in which we work in, how it translates to imperfection at times in terms of diagnostic accuracy and treatment. It's really the humility to recognize that. And I think that we are not there yet, but we're working towards that, meaning that measures that seek to promote 100% perfection in terms of diagnostic accuracy are never going to be received well or carry the impact they could, because it doesn't meet the realities of our complex practice in medicine. And so I think it almost starts with a statement that says, to be a physician is to, at times, err, and that's okay. But we want to minimize that without increasing cost risks to achieve perfection that may never be achievable. And I think if we can sort of adopt that approach, quality improvement strategies will be more successful.
Yeah. Tell me one thing, because I remember, as you were getting involved in this work more, I remember you once saying, I'm not a PE researcher, and we've got a lot of those great PE experts we'll do future podcasts with as part of this collaborative. And it reminds me of sort of thinking about one of the challenges in emergency medicine is we touch everything. And so it's hard sometimes to pick where we want to focus our efforts. Where do we want to try to improve quality? Where are the places where we think we can have the most bang for the buck? And when I think about PE, I still remember when I was a third-year med student, and the sub-I who was the fourth year on the rotation with me, and I did internal medicine first, literally his advice to me was, he goes, every time you're presenting a patient on rounds, just say PE on the differential, because it's always on the differential and you'll sound smarter. And to me now, reflecting on this as an emergency physician and us going into this work, it almost makes it feel like an impossible target then to go after. And so, how'd you get into this PE space, and why should this be the place where we as emergency medicine really think about diagnostic quality versus the million other things that we see?
I think that ties nicely to the prior theme that we were just addressing. So you're right. Any of us who work in an emergency department, particularly if we work with trainees, when is PE not on the differential? Right? The presentation is so protean, syncope, chest pain, shortness of breath, back pain, could be anything. You're right. Much like when you were a resident and someone gave you that advice, how do we reckon with that? But the reason I got into research on measure development in venous thromboembolism, specifically PE, is it is a really nice prototype diagnosis for a couple of reasons. Number one, it is always considered. It is a can't miss diagnosis, at least regarded currently as such. There's been a ton of really important research, I think maybe more so than any other disease, that addresses the front end pretest probability assessment so that we can safely diagnose PE, which doesn't mean we diagnose every PE. It means we diagnose, we choose to take an approach to diagnosis with a disease, PE, that addresses our need to balance resource utilization, risks associated with imaging, with the risk of missing a diagnosis. And that's at the very core of diagnosis in medicine. So PE struck me as an excellent topic for the concept of balanced measures, because a lot of the work that came before has already set the table for this appreciation. However, I felt that maybe the needle was pushed too much. A lot of that research focused primarily on the resource utilization side, and maybe we lost the thread on, hey, how are we performing in terms of actual diagnosis? And so I thought that was a really nice inflection point. How can we retain or carry with us some of the really important research that continues to keep resource utilization as a component of performance measurement, but takes it to the next step where we really understand, okay, what's the impact on actual diagnosis in terms of accuracy?
It's
And I
interesting because
think,
I think that's happening I think we as a specialty hopefully are getting that across a bunch of emergency care. I think TBI, for example. We spent tons of effort that went into the research that created the New Orleans criteria and the Canadian head CT rule. We spent a decade on implementation of those. Even in our Equal network, we did a whole campaign around the Choosing Wisely initiative and reducing CT use. And for like a decade, it seems like everybody was focused on resource use. How do we reduce unnecessary CTs? But now what you see is there was always sort of in parallel happening, it just wasn't getting enough attention. All this research around biomarkers for concussion, understanding the longer term patient outcome, what happens 7 days later. It needs to be more than just figuring out, do we need a CT or not need a CT? It's actually, what is the range of TBI? What is the range of outcomes? What could we do in the emergency department to help it? And it feels like that's where you're taking us with PE, that it's not just about, get the CTs down, but it's actually about what all could we do in the emergency department to actually improve patient health and outcomes after PE is found.
yeah, I think what you're speaking to is calibration of these measures of performance, right? And what is necessary to start this process is kind of a focus, which, as we've alluded to, has been for a number of years on the resource utilization side. But now we got to calibrate some of those measures to make sure it translates into the full picture of performance. And I think you brought up, I think, a really interesting topic when we talk about the range of TBI, right? We got to remember, why are we doing this? And at the end of the day, I think it's to improve patient outcomes. And this speaks to where I think we now may need to go with venous thromboembolism, particularly PE. And that is, I don't think we've even cracked the surface of focusing on diagnosis and PE in a manner that translates into actual patient outcomes. And let me tell you what I mean by that. I think we spent a lot of time focusing on appropriate utilization. We're starting to focus on, are we missing PEs? But not all PEs are the same, right? The range of PEs, as we know, dictate very different levels of treatment, right? From the controversial topic of subsegmental PEs, do they even warrant treatment? To what do we do with low risk PE? Do they need to come in the hospital? Can they go home? What kind of treatment? And we're teasing that out. To high risk PE, where I think really is where the treatment questions reaching the patient have perhaps the greatest impact. And how are we doing in terms of our diagnosis and performance with the highest risk PE, intermediate high risk, the high risk PE, where if we don't treat these patients appropriately with the utmost of care, we may lose an opportunity to save a life or prevent long-term complications. And so I think it's the full spectrum that we're talking about. We can't lose the thread of appropriate resource utilization focus in our measure development and our attention. We can't lose the thread of diagnostic accuracy. We got to remember that within diagnostic accuracy, not all PEs are the same. And do we need to now push this research forward and identify a subset of PEs that are lethal and carry with them now advanced therapies that can really impact patients' lives? Do we need to focus on that end of this as well? And to me, I think it's across the entire spectrum. We're kind of working towards that.
I love that, because I got to tell you, like, as I think about what you just said, this sort of vision for treatment, the role of emergency medicine, how we can really impact outcomes, it's so different than sort of where the history has been around treatment of PE and ED quality. Like, I remember about 15 years ago when I started first getting into quality measure development, a paper had come out of Mayo Clinic back then that showed that patients who didn't get anticoagulation for their PE and the ED had a higher risk of mortality. And it seemed obvious. And then there was a proposal to make a quality measure. around whether or not a patient with a PE and the ED got anticoagulation. Basically, did we give them heparin or not? And it was interesting because at the time, the emergency physicians and a lot of the folks on our expert panels sort of laughed at this. Like, are you kidding me? Like, why wouldn't we treat a PE? Who's not treating PEs out there? And it was a classic example of this being an old paper based on older data. And there being this lag between research and what gets published and what ultimately practices, because we went out and collected some data on it. And sure enough, fortunately, 99% of PEs were getting anticoagulation in the ED, and the only ones that weren't were those tricky cases where somebody has a concurrent intracranial hemorrhage or a brain met that was recently bleeding. And what ended up happening is we then sort of redirected all these PE quality measurement efforts towards the resource side, and sort of thought that there was not much we could do on the treatment side. Was okay, hey, yeah, you got an anticoagulant PE and everybody's getting anticoagulation. But I think you're right, is that all the work that's happening around sort of risk stratification in PE, the emergence of new technologies, interventions, it's really changing. It's not just about, did you get them a heparin bridge to, at that time, Coumadin, or is it about Lovenox or heparin? It's a wildly different landscape now, just as it is for stroke. And so I think that there's a tremendous opportunity there for us to make this much more about patient care, patient outcomes, which will probably resonate with emergency physicians too, in a way that'll be, hopefully push care forward in the way that we've done for stroke and MI, where it's not just about, oh, are we the doctors that sort of avoided the CAT scan?
A good example of this is if I go on a shift and I'm working with a trainee or resident, and I kind of think about, we're seeing a patient and PE's on the differential. I think about what percentage of time we spend discussing elements of this patient's care, right? And I would say more often than not, the residents, because of everything we've just talked about, are much more comfortable talking about, hey, are we going to test for this diagnosis? And a lot of the discussion is around pretest probability assessment, CT utilization, all appropriate. When I work with my trainees after a PE has been diagnosed, and I say, tell me now, how do you think this is the best way to manage this patient? What's the best way to manage this patient? What resources do they need? Can they go home? There's kind of a blank stare. And what that tells me is all the work that's come before that's very important has kind of translated to the bedside, at least in my experience, such that even young trainees know to really consider the front end important questions of appropriate resource utilization. But when you get to the back end of that, the part for the patients who actually have a PE that might impact their care, there's a little bit of a fall off at the bedside in terms of our sort of, not only our knowledge perhaps, but our willingness to have the bandwidth to discuss that. And so when I get to a patient who has a PE and I say to my resident, okay, have you done a risk assessment for the type of PE and match that to the therapy you would like to initiate? There's a little bit of a blank stare at times. And then we have to go through, how does one risk stratify a PE, and then what are the commensurate treatment outcomes? And I think I always, again, go back when I think about measure development, where we've been, where we are, and where we need to go, is what's happening at the bedside. And in my experience at the bedside, we have translated the pretest probability element. Not that we need to stop working on that. It is at the bedside, and that is wonderful. And that is a testament to all the work that has been done in the past and is being done now by researchers in ACEP in terms of quality metrics that shine a light on that. But I think it's now time we bring in the back end, the post-diagnosis appropriate treatment. And that gets to this concept of comprehensive measure development, and that's challenging.
Yeah, no, I appreciate that. I think, but I mean, it's also why it's fun to sort of get in this work now and pull all these EDs into Equal now, because it's not about trying to, rehash something that, like you said, it really has gotten to the bedside, right? Like that research has sort of been out there. People are really structured now. People are doing a great job of that front end decision-making diagnosis. And now this is something that's sort of new to many people, and hopefully we're a safe space for them to kind of come build improvement tools around this, hardwired into their EDs, and really improve care for a lot of patients with PE out there. John, thank you for sitting down with me today. This was fun. I'm looking forward to our kicking off this podcast series around venous thromboembolism. We've got a bunch of national and international experts over the next several months who are going to be joining us. We're going to be talking about the latest in research. I know we're talking about the clinical policies and guidelines that come out and will be out there. We're going to be talking about some high performing centers that have implemented things like PERT teams or other sort of tools to get people with high risk PEs better care. We're going to be talking about what the latest is around anticoagulation. So it'll be a lot of fun, and hopefully we'll have all the rest of you listeners out there joining us on this journey. So
Yeah,
thank you all.
Arjun, thanks. I'm really excited to listen to some of these experts we have coming in. I think this is an important topic, and this is going to be a fascinating series of discussions.
Yeah, thanks, John.